All right, so this is Justine Sparkov. We're going to go through some more interpretation. Now we are going to be working on atrial fibrillation, atrial flutter, and PVCs. So first, we're going to look at atrial fibrillation. So this is usually associated with an underlying heart disease. Atrial fibrillation usually occurs in the patient with an underlying heart disease, such as a coronary artery disease, rheumatic heart disease, cardiomyopathy, hypertensive heart disease, heart failure, or pericarditis. It also often develops acutely with thyrotoxicosis, alcohol intoxication, caffeine use, electrolyte disturbances, stress, cardiac surgery sometimes. Um, and the atrial fibrillation results in a decrease in carbon dioxide because of ineffective atrial contractions. So it's got that loss of the atrial kick and or rapid ventricular response. So clots form or thrombi form in the atria because of the blood stasis or just pooling, and an embolized clot may develop and pass into the brain, which can cause a stroke because of atrial fibrillation. And then atrial fibrillation accounts for as many as 17% of all strokes. So it's fairly a large amount just from this one irregularity in heartbeat. So here we look at the rate. So there's not really a consistent rate here because it's all over the place. So the atria can be anywhere from 350 beats per minute or greater than that. And then the ventricular rate, so the ventricles, as far as their rate, are varied as well sometimes. The rhythm here, like I said, is irregular. There's no consistent beat going on here. If you look, you got a space here that's huge, and then over here you got a smaller one, a little bit bigger, now a smaller. There's no rhyme or reason. If you try and look for those P waves, you can't really tell where they're at. You're like, well, maybe that's one, or maybe there's one there, maybe one there, or maybe it's here. So P waves you can't really see because they're just kind of all over the place. So you could say there's none. And then again, if there's no P waves, you can't measure PR interval. And then that QRS is within that normal limit of 0.06 to 0.10 seconds. Now, we also call this heartbeat or this heart rate irregularly irregular because it has no rhyme, no reason, no rhythm whatsoever. So if you want to think about it, we know that the conduction of the heart, this is what it normally does, is the SA to the AV down to bundle branches to the Purkinje fibers. So what happens in atrial fibrillation is if you think of the SA node as 8 kids talking all at once, and so that's like 300 firing. So you got boom, 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 kids talking all over the place. So it's firing, firing, firing all over in the atria, okay? And the AV is the husband or the mom, the AV node is trying to filter out all those things those kids have to say. And they have to be selective about when they fire or when they listen to something they have to say. So maybe they only get 150 things that the kids are saying, or if they only fire 150 times to the SA nodes 300 times. So that's why like the P waves are kind of all over the place, and then the ventricles try to follow behind, but they can only understand 150% of whatever, or 150 um, things of what the 300 things that the kids are saying. Okay. So again, it's firing all over the atria. The SA node fires, and you get random firing all over the atrium up here. Okay. And then the ventricles fire off every so often. They filter out a few of them. They can't keep up essentially. So again, there's no P wave. So what would someone look like if they had atrial fibrillation? They would have palpitations probably. They could be hypoxic. They could have chest pain. They could have shortness of breath and dizziness. So how are we going to treat this? So the goals of treatment here include decreasing the ventricular response to less than 100 beats per minute, because we know if we um, get it to slow down, we get better squeezes from those ventricles, so that way we get a better push out to the organs and the brain and everything to get more blood. And then prevention of stroke also occurs. And then the conversion to sinus rhythm, if at all possible. If we can convert them back into normal sinus rhythm, that'd be great. So we can do ventricular rate control, and that's priority for the patients with atrial fibrillation. So a lot of time we use Calcium channel blockers like diltiazem or beta adrenergic blockers like metoprolol or digoxin or amiodarone to help control the ventricles. Now, for some patients, pharmacologic or electrical conversion of atrial fibrillation to a normal sinus rhythm can actually be considered. So, like reduced exercise tolerance with rate control drugs, being have a contraindication to warfarin. If if we're going to use the electrical conversion, it may just be because we can't because they can't tolerate that exercise and they are maybe allergic to warfarin or something that's in it. The most common antidysrhythmia drugs used for conversion to and maintenance of sinus rhythm include amiodarone and ibutilide. Electrical cardioversion may convert atrial fibrillation to a normal sinus rhythm, which is actually what we want, so that'd be good. If a patient's in atrial fibrillation for longer than 40 hours, they need to have an anticoagulation therapy with warfarin for like 3 to 4 weeks before a cardioconversion can actually occur. Um, and then for several weeks after the successful cardioversion, just so that way they don't end up throwing a clot and again having a stroke. Anticoagulation therapy is necessary because the procedure can cause the clots to dislodge. So if there were clots in that heart before we cardioverted, we don't want there to be any more clots and then to be dislodged. And again, put them at a higher risk for a stroke. We can do a transesophageal echocardiogram, which can be performed to rule out the presence of clots in the atria. If there are no clots present, anticoagulation therapy may not be required before the cardioversion procedure, but that's only if they've gone ahead and taken that extra step to look to see if they're there to begin with. And if drugs or cardioversion don't convert atrial fibrillation to normal sinus rhythm, they may have to be on long-term anticoagulation therapy. And warfarin's usually the drug of choice, even though times are kind of changing. It's typically the drug of choice, and patients are monitored for therapeutic levels with their INR level. So biggest thing here is we don't want them to throw a clot. So if we can cardiovert them, that's great. If not, they'll have irregular heartbeat the rest of their life, and they need to be on anticoagulants so that way they don't throw a clot. All right, let's talk about atrial flutter. So atrial flutter can be the first indication of a heart disease. So it's an atrial tachydysrhythmia identified by that recurring regular sawtooth-shaped flutter waves that originates from a single ectopic focus in the right atrium. So this is what we call a sawtooth, where it kind of looks like if you hold up a saw blade to kind of get that sawtooth. So this is the atria. One spot in the atria is kind of irritable, if you want to call it, and it keeps firing and keeps firing. And the ventricles just kind of clip along at their own pace, but the atria just keeps firing away. So the rate here for the atria is anywhere from 250 to 350, and the ventricular rate, again, is variable. It just depends on the underlying rhythm. The rhythm itself, the atria is regular, and the ventricle is variable. So it just kind of clips along. P waves, so they get the flutter waves with sawtooth appearance. So if you say P waves, you can say sawtooth would be a good description of P waves. PR interval, again, because they're so varied, there's one here, you can't measure a PR interval when R is all the way over here. So that would be variable. And then QRS is considered normal. So if we're going to do our measurement here, that would be normal. All right, so like I said, one spot has kind of gone crazy in the atria and keeps firing, and only a few actually get through to the AV. So maybe right here is the irritable spot, and so it fires, it fires, it fires, it fires, and then finally one gets through to the ventricle. So then all of a sudden you can see QRS, and then we see a P wave, P wave, P wave, P wave, P wave, and then one gets through the AV node, and then we get a QRS that fires off. Okay, so that's really what's happening is there's just one spot in the atria someplace that just is kind of irritated and just keeps firing. Okay. Now, signs of someone who is symptomatic would be anxious feeling. They could have that flutter feeling in their chest with the atria keep going, so they may feel that kind of that flutter, and then they may also describe it as palpitations. So our treatment here is usually calcium channel blocker like diltiazem or beta blockers. So that's how we would treat this. But there are some people who are asymptomatic and don't even feel it until we hook them up. And then finally, the last one that we're going to go through during this PowerPoint slide is our premature ventricular contractions or PVCs. So these can result from irregular ventricular activity. Patients can sense PVCs as like a skipped heartbeat is how they kind of describe it. Or with PVCs, the ventricles are only partially filled, so there's no pulse generated with it. So if I'm feeling a pulse, sometimes we're not going to feel that pulse. You may hear it, but you may not get a full pulse from it because it's only pushing out half the amount of blood that a full heartbeat would. So when every other beat is a PVC, the rhythm's called ventricular bigeminy, meaning by every other. And then when every third beat is a PVC, it's called ventricular trigeminy. Again, every third tri. And two consecutive PVCs are called a couplet. So if you have two in a row, that's what we call them. They're a couple. They go together. Our PVCs look like this. They kind of look wide and bizarre. They're really wide because what's happening is the heart is firing off regularly, essentially. So it goes SA to the AV, down bundle branches, the Purkinje fibers, and then all of a sudden, you have one spot that's kind of mad and it fires here. Well, then it's gotta work backwards before it can go forward. So the electrical impulse kind of works backwards, and then all of a sudden it's like backing up a truck before you can go forward. You gotta back it all the way up to the beginning and then you go forward. So that's how you get that wide, bizarre um, PVC. I kind of say it's a spot in the heart that's pissed off. Is a PVC is how I kind of remember it. They're often associated with stimulants such as caffeine, alcohol, nicotine, uh, aminophylline, epinephrine, isoproterenol, and digoxin. They're also associated with electrolyte imbalances, hypoxia, fever, exercise, emotional stress, and disease states associated with PVCs include like an MI, mitral valve prolapse, heart failure, or coronary artery disease. However, PVCs, the great thing is, are usually not harmful in the patient with a normal heartbeat. In heart diseases, PVCs may reduce carbon dioxide and lead to angina and heart failure, depending on the frequency of when they occur or how often they occur. Again, irritability of the conduction system is what causes it, so I would say it's a pissed off heart. Um, Another way that you can help think of it is kind of like that hyper kid in class that can't wait their turn. Yeah, they wanna keep raising their hand. They just shout out whenever they want, and so that's that blue spot here is that kid that just can't wait his turn and just all of a sudden shouts the answer, or can't wait to raise his hand and just, shoots, okay? So the impulse has to go backwards to go forward, so backing up the car is slower than driving forward, so you get that wide QRS, and it's usually wider than that 0.12 QRS complex that we measure. So some signs of someone who actually can feel it or symptomatic. Basically, if the patient can sense PVC says skip beat is about the best description that they give. And there is no treatment, just treat the underlying cause. So if they're drinking a lot of caffeine or have a lot of stress or anything like that, then you would obviously help to try to eliminate the stress and maybe stop drinking caffeine or alcohol. Okay, now I'm going to go ahead and I'm going to switch views again to our assignment that goes along with it here. So give me 1 second. All right, so here is your assignment. I want you to work on this atrial fibrillation practice that's in your packet. And then I want you to go ahead and go down and work on our atrial flutter practice and complete that. And then are PVCs. Now, one thing that I do want you to keep in mind, there's really not anything to do here, they're just examples of PVCs, is that PVCs are not a diagnosis. So if I were to look at this and say I went through, this is 1, 2, 3, 4, 5, maybe 60, I'll say, because there's another one here, 60 beats per minute. And I did all the measurements and everything. I would say maybe this is, I could say this is bradycardia, normal sinus rhythm, bradycardia with one PVC or with a PVC. You have to tell me what the underlying rhythm is, and then you just add on with a PVC. Okay. So again, like if I want to say this is 50, I could say this is bradycardia with a PVC, normal sinus rhythm or normal sinus bradycardia with a PVC is what I'd say. If it's fast, I'd say um, sinus tachycardia with a PVC. Okay? So always tell me what the underlying rhythm is, and then just add on the with a PVC. All right, so that's it, and look forward to the next recording.